welcome to this skill video. In this one we're going to be running through a synchronized cardioversion. So what is a synchronized cardioversion? Essentially it is a timed application of electricity to a specific point in the cardiac conduction cycle. We synchronize the shock or the electricity that we're going to provide with the QRS complex in the cardiac rhythm, because that's the maximal point of cardiac depolarization. The idea is that we are going to terminate an unstable tachyarrhythmia and allow for the re-establishment of a normal sinus rhythm underlying. And the reason we synchronize this shock to the QRS is because it allows us to target our electricity to within a safe part of the cardiac conduction cycle. Therefore, it reduces the risk of an R on T phenomenon into a cardiac arrest rhythm like VF, and it requires less energy to also achieve that complete depolarization of the myocardium. This is different to a straight defibrillation, which occurs at a random point throughout the cardiac rhythm. When do we do it? Well, we perform a synchronized cardioversion when we find a patient who's presenting in a poorly perfusing tachyarrhythmia, such as a VT, an SVT, a rapid AF, or a low ratio atrial flutter, such as a 1-in-1 or a 2-in-1 flutter. And the goal is to restore normal perfusion by terminating those high heart rates. When we are presented with someone in a pulseless shockable rhythm, we should always opt for defibrillation. So we do need a few pieces of equipment when we're intending to cardiovert someone. And from a safety standpoint, it's best to think of this in the same way as you would think of a procedural sedation, which we'll talk about later, or an RSI of a patient where we take over control of their airway. Because in either case, the worst case is that we have a complete airway collapse or a circulatory collapse into cardiac arrest. So to that end, we'll require a bag valve mask with an end-tidal CO2 detector attached. We'll require some rescue airways in case things go wrong, and here we've got an IG oropharyngeal airway and a nasopharyngeal airway. We need our medications to provide pain relief and a degree of sedation. Here I'm using ketamine, midazolam, fentanyl, and I have also adrenaline drawn up ready to go in case we do cause a cardiac arrest and we need to therefore work through cardiac arrest management. We also need our monitor, which is capable of synchronized cardioversion. Here we're using the Zol X series. So before we perform our actual cardioversion, we need to make sure that we're well prepared. This not only includes having our equipment set up, it also includes having our patient well monitored with both cardiac monitoring, blood pressure and SpO2. It also involves optimizing the patient's position and oxygenation. We'll do this by placing them in the airway position or ramping them up and pre-oxygenating them with 100% oxygen via mask for a good period before we provide any sort of sedation or intervention with electricity. We'll also ensure that we have bilateral IV access and that we have fluids running. So there are a couple of options in terms of pad placement. You have your standard anterior lateral positioning that you would normally use during cardiac arrest, but there's also anterior posterior, which provides an alternate pathway for the electricity through the heart muscle. And that placement is typically recommended in transcutaneous pacing. So as you can imagine, cardioversion is quite painful. We're literally providing an electric shock across somebody's chest. So it's a good idea, if possible, to procedurally sedate our patient. This may not always be safe, particularly if the patient's severely compromised. So we may need to just provide a degree of pain relief. And that's particularly the case when the GCS is significantly decreased and we're concerned about an impending loss of cardiac output. So basically, while it is ideal to provide a degree of sedation and analgesia, if you need to do it now, you need to do it now, and you just do it now. So prior to cardioverting, we're going to want to double check our rhythm, and we'll confirm it with a 12-lead ECG. We also want to confirm that our patient status is such that we really are required to perform the cardioversion immediately, and that it's not something that can either be managed with an antiarrhythmic or wait until the patient arrives at hospital. So after confirming our cardiac rhythm and our need to intervene, and with our patient pre-oxygenating on high flow oxygen, it's time to start pushing our medications. Now, there's a number of options that we have, depending on what level of sedation and analgesia we're intending to provide. If the patient's stable, relatively stable in this sense, we would aim for a degree of sedation so that they are not only pain-free, but they're amnesic to the events that go on. If that's not possible and they're quite compromised, or if the cardioversion has to happen quite quickly, we may only be able to provide some basic pain relief, such as fentanyl. If it has to happen right now and we are staring down the barrel of an impending cardiac arrest or complete loss of output, it may just be that we have to warn the patient that it's going to hurt, and we shock them anyway. So as our patient is relatively stable, we've opted to run with a degree of sedation prior to our cardioversion. In this case, we're opting to run with ketamine. 1 milligram per kilo. The patient is 80 kilos, so he'll receive 80 milligrams of ketamine. We also have the option to add midazolam. This may be quite a good idea, both for the emergence that you can get with ketamine and also just to increase that level of amnesia so that the patient doesn't remember what's happened. So with the patient adequately prepared and sedated, we'll then move on with the process of actually delivering the cardioversion. Here we can see we're in a VT at a rate of 180. With our Zol, we have a soft key here, which we hit for sync, provides us with an S above the QRS complex in each beat. We then we select our energy, in this case 100 joules for the first shock, and we charge. Ensuring everybody's standing clear, we'll call all clear, and we'll deliver the shock. Here we see that we've successfully reverted to a sinus rhythm, which is the goal. Should our first cardioversion fail, we can then attempt again with a higher level of energy. We might move to 150 for a second shock and ultimately 200 for a third cardioversion. It's important to remember that once we have reverted the patient back into a normal rhythm, we are still under the effects of our sedation and our analgesia. So we are going to have to continue to monitor our patient and to provide ventilatory and circulatory support as required.